So much for having me, and I'll do it again. So hi everybody, and we'll back to hi Dr. Nick, all of that good stuff. What I'll do is I'll run through a little bit of an introduction first, kind of understand what we're going through for most of the concepts that we're going to be talking about. And mostly this will be video based, but I guarantee you I will be showing you things today you have never seen before. I'll make reference to the books and see how we incorporate that information into it and to the online content and all of that good stuff. But the key thing for this to be the most useful for me and the most useful for you who are observing this is to ask lots of questions. It actually works better for me when I'm presenting if people interrupt and ask questions. So Shelly will be setting those up in the chat for everybody who wants to observe with this, but please ask lots of questions. When I show you something, if you want me to play it again, I can definitely do that or go over the content. Of course, it's not as dynamic as an interaction in person, but it's still going to be very useful for all of you to see this. And like I said, you'll see things you haven't seen before. And please ask me lots of questions. All right, the next thing is going to be, I was reflecting on this presentation before it started up, and had a preceptor student who is a naturopathic doctor, basically ready to graduate here in 2 months. So he's got 8 years of post-secondary education, and he observed our treatments, and he was surprised how little it takes to actually make somebody feel better. And I'll keep that as a theme for today's presentation because we're going to start off with the anatomy. It'll mostly be anatomy based. Then I'll go through some of the assessments, and you're going to hear me say this repetitively. Your assessments are therapeutic. And maybe you should just say it with me with a smile. For those of you who present with me, no, assessments are therapeutic. Say it with a smile. Assessment is therapeutic. And he was surprised how little we had to do. So one of the key things I want you to keep in mind, yes, we're going to talk about the anatomy, we're going to break it into the assessments, and then we're going to bring it over into the actual treatment plans that we might follow with this. Minimal effective dose. If you are a smart student right now, you've probably got a piece of paper with you and a pen, and you're writing little things down. Minimal effective dose is always on my mind, thinking of the key things. What is the least I have to do to help this person meet their goals and outcomes for today's visit? And then focusing on longer term goals through the treatment plan later on. All right. So hopefully that's a good start for everybody right there. So our process for this entire session is going to be anatomy, then we're into assessment, then we're into action. Any of the things that I talk about, I'll do a quick screen share right here, are available. Oh, we're not ready for this one yet, although we will be shortly. We're not ready for this one yet, although we will be shortly. Just go onto our website and you can find most of this information. A lot of the videos that I'm going to be presenting, some of the Cadaver ones aren't there, but most of them are. We can see where we can have the anatomy, where you can look up from Gray's Anatomy. Any of the range of motion and muscle testing you do for your assessment, I'm just picking the head and neck. There is video for all of that content. There is also a video on all the specific muscle testing you can watch with links to the actual textbooks as well. So that chapter from the muscle manual is there for muscle testing. You also have all of your special tests that are there with links from the orthopedic assessment text. And then you would have the same thing for the conditions, where I walk you through each of the conditions, how you would treat them, key things to look out for, red flags, all that good stuff. And of course, all of our other action options that include exercises, patient handouts, and all of that. So there are resources available for you to use outside of this presentation. All right, but where I'm going to start for us is looking at just some of the basic anatomy. So right now, we've got a dissection here that is showing us the platysma. I'm just going to let it play here for a second. One of the key things that I try and do is I try and show layers. Like basically when you're looking at a person, or when even you're looking at treatments, we're going through layers of options, right? Layers of options of what can I do? What can the person handle today for my treatments? And more specifically for our anatomy, where we're starting, layers of the body that we would palpate through and apply our manual therapies with, and our exercise therapies as well. So this dissection is of a donor who was around 58 years old. And here you can see this is the front of the neck right here coming down. This is skin over top of the neck. This is normal. This person was not overweight or anything like that. This is normal subcutaneous adipose or superficial fascial layers, as you might see Gil Headley and other people I've dissected with call this. But we're going to peel it back, and I just want you to see what it looks like in a fixed donor. I guarantee the vast majority of you have probably only seen cadaver content on a fixed donor. And I'll let this video play. I'll talk us through it. And then I'm going to show the same area in an unfixed donor. So it'll more represent what you would see in real life on a patient. Still doesn't have resting muscle tone or anything like that, or the blood flow through it, but would be a starting point for us. So if we let this video play, we can see that we've already made our incisions. It wouldn't normally peel back this well. The donor's ear is here. This is the jawline where we made the incision. And we can see, you know, where there would be beard hair and all that, and you would peel this back. So a couple of neat observations for people just to begin with. This here is the underside of the skin, and you can still see the hair follicles. And this is thick, like I'll tug on my own beard right here, okay? This is the hair follicles that are in the skin. They are buried in the skin, but they only go as thick as your skin actually is, which is going to be anywhere from 2 to about 5-6 millimeters, depending on where you are in the body and how much irritation and thickness of the skin you have. Being thick-skinned is actually something that does change with repetitive irritation and load over top of it, but we'll get back to that in a second. Okay, so here we can see superficial adipose, and then you can see these wispy fibers right down here at the tip of my probe. We'll let this play. Wispy fibers right there. Those are the fascial fibers of the platysma on a fixed donor. So you can see them closer to the anterior side of the neck. When we palpate someone's neck, one of the first things that we see, our palpate, is going to be through the skin and into this area right here. And if you pick the skin up, you are absolutely positively picking up platysma when we do that. And you can see how when I pull on the skin, it pulls on all the adipose and subcutaneous fascia that would be there. It would be a little bit more fluid at room temperature, and I'll show this in a second, and in a normal body with blood pumping through it. But kind of neat for us to see the layers just to start with, to give that context of putting our hands on somebody and what we're actually doing. We are influencing blood flow, adipose tissue, neural stimulation in the area, as well as eventually reaching deeper into the muscles. So kind of neat for us to see that. I will let this, scoop underneath there just a little bit, and you can see actually how thin the platysma actually is. We're looking at maybe 1 millimeter to 2 millimeters thick on this donor right here. Even though you look at your anatomy texts, and we'll go into one of those right now. So if I go back to my screen share, most of the stuff that we wind up doing is going to be, oops, I got to fade through right here. Zoom's giving me, sassing me a little bit here. Let me just scroll down just a bit. You guys are going to get to see more of my background, my work environment. But if we look through most anatomy texts, what do we see for our content? The Orthopedic Conditions book, by the way, also available through your MTAM representatives. But when we go through most of our anatomy, this is the head and neck chapter that we're going to be going through here just a little bit. We usually start off with the bones, and we see how nice and clean everything is, and we can label all the facets. In fact, I could stop this video right now and pull any of you out and say, can you give me the origin and insertion of any muscle? And you'd have no problem with doing that. I could say, label all the parts of any bone, and you'd have no problem doing that for me as well. You know, all that good information that we have to know from school, right? I'm still going to encourage you strongly. You're like, yeah, right, Dr. Nick. I'm still going to encourage you strongly to go back and review this information. There's a reason in every single book I put it there for us to begin with, so we can go back to that anatomical foundation of information. Our next layer is going to be, of course, the ligament layers that you can see here. And of course, everybody remembers the posterior longitudinal ligament running down, the nuchal ligament, the anterior longitudinal ligament, all of that good stuff. And of course, the more details that you see deeper down once you get into the cruciform and all those other ligaments. I'll show some cadaver dissection on that in a little bit, how it's not as clean as it actually looks in the books, and how it's not as clean when you actually look at this on a unfixed donor as well. Those of you who have hunted before understand this. Same thing here into the muscle layers. I mean, we could easily make this into a quiz for everybody. Again, I would encourage you all, you see me putting up my prayer hands, please pay attention. Know your anatomy when you're working on somebody. Look at the size of this platysma right here. You can see how most artists draw this. These are not from H.G. Carver. These are from, what is his name? Artistic Anatomy, Paul Richer. So these are from Paul Richer, who is an absolutely amazing artist. And you can see that would be our perfect rendition of platysma, but it's only millimeters thick. It's buried in the skin, superficial, very small muscle. We'll get into all the SCM and all that in a little bit. I'll show the scalenes and brachial plexus. I'll also take us through our layers on the back of the neck as well, where we can go through suboccipitals like trapezius, splenius, and then getting into the erector spinalis, and then the suboccipitals further down. But again, it's not like you learned it in the textbooks, and it might not even be like you learned it off of your cadaver dissections if you've done that as well, if you haven't seen unfixed donors. Where do we see this in real life? And I will come back to the importance of diagnostic imaging later on. It's highly overrated in the vast majority of the patient population. And I'll maybe even do a tidbit right now. Did you know if a patient reads an MRI report, their symptoms will actually be worse? There's research on it. It is clear. It is our job to normalize what is there for the anatomy, and normal age-related changes is one of the biggest tips I'm going to give today. But regardless, here's me getting an MRI done, super happy camper, and you can still see this structure right here. So all the stuff that we just went over, you can go ahead and see right there. So I'll kind of leave it at that for our introduction for how you've probably seen your anatomy before. What I will do now is switch over to our second video, which is going to be a unfixed dissection that's going to show the anterior side of the neck. If you haven't seen this before, I'll give a little caveat. The first thing I will say that I should have said at the very start, we are all, and I am especially, forever grateful for all of our donors for giving us the privilege of donating their bodies for us to gain this knowledge base and understanding. And if you've not seen unfixed dissections before, you're going to see a lot of vascular tissue here with this dissection. So if you've hunted, that's no problem. I know many of you have. So if you've processed an animal before, you've seen what this tissue actually looks like. So it looks a lot bloodier, basically, is what I'm trying to say. So just give you that warning before we get into it.
Nick, before you keep going, can you just be a little bit more clear about the difference between fixed and unfixed tissue?
Yeah, totally. Let me go back then. Yeah, great one. Good, Shelly. And interrupt me like that every single time. I need more interruptions. Okay. All right. So fixed tissue, the muscle doesn't look the right color. Okay. So, and what I mean by that is it doesn't have the hemoglobin content in it that is actually going to show you what it really looks like. So like, even if we look at this video here, how do I know this is fixed tissue? Number one, the skin is not quite the right color. If you look up here in the upper right, you can see the muscles usually a brownish color. Let me just scroll down here a little bit. Yeah, we zoomed in. Unless the embalming agent like your phenols and your formaldehyde didn't get in there very well. I don't want to give it all away for you. You'll be able to tell right away what is fixed and unfixed, but this is definitely fixed. Like, see this brownish color up here on the neck? That is a fixed muscle tissue right there. That has embalming fluid. It has different phenols and formaldehyde in it, basically, that allow the tissue to be static so it doesn't flex or move, but it also means that bacteria won't break it down. Our current cadaver that we're using, we could have that donor for probably 10 plus years and the bacteria wouldn't break it down. So that's what a fixed donor is. Unfixed donor means literally nothing has changed. There's been no chemical additives put into this person's body to stabilize the tissue. And they are probably at room temperature, because as we know, after you die, you start to get closer to room temperature. So as our transition, you can see the one video here with this, which is fixed tissue. And then I'm going to jump right into the next one. And we're going to start super basic with this platysma. And this will show you what unfixed tissue looks like. So give us a second to get around. It can look a little bit gory for some people. But as we progress into here, so can everybody just clearly visualize the difference here? Basic orientation, this is the person's jawline right here. This is the suprahyoid muscles coming down. This is the thyroid cartilage. So if you palpated the front of your Adam's apple, that would be right there. And over top, like, just look at how much, and I don't want to make the equation to food here, but you kind of have to look at how much juicier all of this is. This is what real tissue looks like when you look at it under surgeries. I've seen a number of surgeries when I did my time in the Portland Providence ER volunteering and as a resident, effectively, is what they made me. And it looks exactly like this when a surgeon cuts into somebody. Of course, they would never take all the skin off like this, but can you also observe how vibrant the fat looks? Look at these fascial membranes. We say fascia looks like saran wrap over top of muscle. That is exactly what it looks like when we're going through here. So this is the person's deltoid on the far left. This is the pectoralis major coming down right here. And just because of this, the plane of the shot, like the arm is running out to the side, you cannot make this stuff look pretty. Like, it just looks like this. Like, even all the wraps and everything like that we have to use, all the cloths and everything, you just get tissue everywhere when you're doing this. You only actually have about 3 days with a donor before the bacteria just naturally in the body and in the environment start to break it down, and the muscles kind of lose a lot of their structural integrity, I guess is the best word. I don't know, Shelly, does that answer that question right there? I hope. Didn't want to spend too much time.
I think so. You're good.
Yeah. All good. All right. Perfect. Okay. So I'll let this play here. So the first thing I want everybody to get, number one, I can tell this is a geriatric donor because we know as our part of our natural aging process, the jaw actually gets thinner as you age and you start to lose your teeth. There's me outlining the thyroid cartilage, suprahyoid muscles. Even watch how the probe sinks into the muscle. I'll stop this for 1 second. If you take and you palpate your own forearm, or because we're doing the head and neck here, if I take and I palpate my SCM especially if I turn my head like this muscle right now actually has tone in it. Which way looks better? Yeah, this way looks better. You can see it better. Okay, so if I spin off to the side like this muscle has density, but you can see how it slides back and forth underneath the skin. Right now, we're writing a new mini book for massage therapists that includes chapters and sections on zero friction interfaces. Well, that's what you have here. You effectively have this zero friction interface where your skin is going to slide, number one, over top. The muscle is going to slide below that. It's what allows you to move through space in different positions, is that zero friction interface, but it's all facilitated by fluid inside of the body between each of the fascial membranes and synovial fluid inside the joints and all of that. So if we go back to our screen share, I mean, this is just such super cool stuff. If you haven't seen it before, I would encourage everybody to go and be involved with some kind of animal dissection. We actually do pig dissections as well. So at the very start of the session, the pig will be alive, dispatched, and on the table within 5 minutes, so you can actually see what the real tissue is like. If somebody wants me to show some video of that, I can definitely do that later on. But this tissue right here is still reasonably close to that. It's just at room temperature, not body temperature. So it would be about another 15 degrees warmer typically is what we're looking at. But watch the tip of this probe, how it sinks into the muscle. If this was fixed tissue and you tried to put the probe through it, it would actually cut the muscle apart and damage it. And actually tear the fibers of it. So this right here, we're going to jump around just a little bit. That's going to be upper portion of masseter. You can see how platysma becomes continuous with that and blends in to the clavicular head. And there's the sternal head, and there's the clavicular head of the SCM. And it sits superficially over top and then blends into all the tissue around it. Here we are putting the skin of the neck back on. And again, oops, we'll move it back just a little bit because the camera moved right there. Again, look at this tissue. It looks like living tissue. You can feel how it bends, how it moves. Fixed tissue skin doesn't give you anything nearly the same semblance of what you actually get with unfixed tissue. So we can just see the skin right here, how it would slide back and forth. We have like little, the palpability, the malleability of the tissue, substantially better, and how much more fluid it actually is. Even this up here in the lower right of the screen, I'll just pause this for a second because we're going to dive into this area in a second, is showing us the upper portion of the clavicle. Bones are not white. I can't stand it when you see drawings where the bones are like pure white. That is not what a real bone actually looks like. A living bone has almost a lighter skin tone to it, or yellowish color. So kind of neat for us to see. And then again, fascial layers with investing adipose tissue all the way around. This is a normal, healthy body right here that we're looking at. I believe that this donor actually died of cancer. That's what we tend to get for most of our geriatric donors, either going to be a cancer or a pneumonia or something like that. Seen a number of them over the last 20 years, but yeah. All right, so that gets you through fixed and unfixed tissues. So I'll stop my screen share right there, give Shelly a second to ask if she has any questions. And I'm going to say no. All right. And that's going to go ahead and get us to move on right here. So now we're going to progress into key areas that you want to be aware of. If you've been with me before for presentations, we'll be out in Winnipeg in August to do a bunch of stuff there as well. You have probably seen this video before because it is literally one of my favorites. So fixed or unfixed? You should be able to answer this question for me right away. Fixed or unfixed? This is obviously fixed tissue. You can tell because the muscles are stuck like a picture in this position. They're not malleable and bendable or anything like that. The other thing, even the adipose doesn't look quite right, like the yellowish color is a little bit different. The real advantage, though, when you are a student, especially first time learning, it's easier for you to find structures. Now, even this dissection right here, this is probably about 25 to 30 man hours of dissection just to get down to this point. It really is an artistic creation of the person who did the dissection. So I dissect with a lot of different people. Many of them help me out. And actually, I'll put that out there for you as well. We are doing a cadaver dissection in June, end of June, 24th and 25th. If anybody wants to fly out here and join that, I will put the link up for everybody to have a look at. I only have 2 spaces left. We can only fit 8 people, so it's a pretty selective group, but it's nice because they're all professionals, so we get to talk about it, and it will be a fixed donor specimen. So, all right. So a couple of key things for you to get right here. Number one, outline of the clavicle. I'm just going to run through all of these structures. This is me running down with the probe right here, showing you where the omohyoid would be. There would have been a bunch of other fascial tissue right here. If we lift up the omohyoid, you can just see right in front, the probe is at the anterior scalene muscle. Then you can see the middle scalene, and more of the fascial membrane behind is going to be the posterior scalene. But what I'm really trying to show in this video is the size of the brachial plexus. And it varies. I'm going to show some suboccipitals here in a little bit. The suboccipitals will vary in size depending on the size of the person. So if you've only seen one cadaver or two cadavers, you haven't seen much. But just as different as we all look in the patient population, that's how different each donor actually looks. So I'll show you a large suboccipitals here in a little bit. But most people are taught this incorrectly. So let's just stop for a second. In fact, I feel like I've been talking for a while here. So why don't we all just take a little breath? Big breath in and all the way out, and maybe bring in some neck stretches since we're talking about these muscles. Had another patient in on Friday. She goes to me, I just don't like doing my neck stretches because I don't feel like they get to do anything. Well, and she said she grips like this and brings her head over. I'm like, hey, what if we have you reach down further and do some micro movements? I don't need to be on the screen share for this, and do some micro movements. And I know we all do this, but it might be back to that assessment and treatment option that we're going to be going through with this. Why not smell that armpit and move down? But give patients the permission to find whatever range feels the tightest for them. For some of you, it's going to be like this. For some of you, it's going to be like that, wherever that range is. Now I regularly get my neck torqued on in jiu-jitsu, and so I have some pretty decent flexibility, but the goal is to have that flexibility with strength and kind of work your way through it. Same thing other side. If you're watching this at home, do your stretch. So big breath in, and then all the way out. Bring yourself over and see that anatomy stretch out. Smell that armpit. Oh, yeah, still clean. All right, good. Moving down. Nice. Okay, now I can get back into talking to us more about these scalene muscles. So when you see the person kind of stretching over like this, obviously that is SCM coming down right there. And most students are taught, because there's a drawing from Netter that almost everybody uses, that it goes anterior scalene, middle scalene, posterior scalene. That is not how it goes at all. So it goes anterior scalene, yes, just lateral to the margin down here at the clavicle of the lateral to SCM is where you're going to find anterior scalene. But the next thing you hit right above the clavicle has to be your brachial plexus. Back to assessment, basic palpation, if you know your anatomy, has huge value. A basic orthopedic test that I actually taught a class on Thursday, and the students were amazed how quickly I found it, when all of you are experts at this, would be the doorbell sign, where literally we were doing a brachial stretch test. So bringing the arm back like this, and I'll show that brachial stretch test in a second on that cadaver dissection. The arm extended back like this so you can see everything. And she's like, yeah, I get numbness and tingling right here in my C6 dermatome. And I'm like, great. The next place that I go is not going to be pronator teres, is not going to be the carpal tunnel. Because she said C6 dermatome, I went right to the scalenes and I started out nice and lateral to make sure she was okay. And then we came in right here between anterior and middle scalene and pushed in, and the doorbell sign is literally ding dong, and numbness and tingling starts and numbness and tingling stops. Numbness and tingling starts, numbness and tingling stops. So we were able to relatively rapidly, minimal effective dose, isolate where the tissue pathology was. And that's why the anatomy is so foundational. Please hear me on this. If you don't know your anatomy, you can't follow the rest. It's like a mechanic working on a car that's never seen the inside of a motor or anything like that. Like it would be crazy. Okay. Excuse me. So anyways, so we pushed on that, and then right away she said, oh, actually that felt kind of good to push in there. It gave her the numbness and tingling, but we could start to move through and separate out and increase blood flow and neural stimulation and all the other benefits we get from massage therapy in that area. So back to this video. We'll just let it play right here. Look at the physical size of the brachial plexus. It is way bigger than you think it is. Again, anterior scalene, brachial plexus, then middle scalene, then posterior scalene. And in a real donor, before we actually took all the time to dissect everything out of here, there would have been of all kinds of adipose and other connective tissue that filled this space up as well in that supraclavicular fossa. Super cool? Super cool. All right, so I'll let it play out right here because there's a couple of other nice things that we show on this one. It literally is one of my favorite videos that I've done since, dissecting since 98. So what does that mean? 25 years of this already. Yeah, so you can see there what I'm talking about. There's SCM put back into place, running your finger over to the lateral side. You are hitting the brachial plexus, and it is okay to treat over top of the brachial plexus, okay? And I'm going to stop for 1 second right there. It's actually okay to treat over top of the carotid arteries and everything as well, as long as you're not pinching both sides off like we do in Brazilian Jiu-Jitsu with a nice choke, okay? But regardless, as long as you're treating on one side and the pressure's not excessive, as long as you're only treating on one side and the pressure's not excessive, it's not a big deal if you're not causing tissue damage. Okay. All right. So there I'm just showing the anterior scalene. We'll just gun through this a little bit faster because we have a lot of videos to show you guys today. But okay, this is where I wanted to get to right here. Let's go back just a little bit. This is pectoralis minor in place. You can see the brachial plexus running underneath. Again, it is not like you learned it in school. All of us have to take that brachial plexus and draw it out. How useful has that skill been for you in practice? The only useful portion of that is understanding how the nerves actually run. What does the brachial plexus really look like? It really looks like this. It is a cylindrical neurovascular structure running down where the brachial artery and axillary artery and the subclavian artery, which is all the same tube, just change the name as you run down, have this network of nerves wrapped around it. This is a good, safe evolutionary development for the body because it's buried way up in your axilla. When I teach the instrument-assisted classes, what are we trying to do? We are definitely not pushing up in here with an instrument, but you can start to work in other areas around here. The brachial stretch test, we're going to demo that again on this cadaver. And this is the key thing I want people to realize when they're doing their assessments. And you can turn this assessment into therapy. You can stretch nerves, and it can be a nerve flossing variation, but I think we can do better than nerve flossing. So let me just play this really quick so we can see it. So we can just run through here, upper portion of the brachial plexus. You know, we're dealing with a lot of arm pain because, of course, it's where the nerves run from clinically when we're looking at people. But we'll start to lift the arm above the head here shortly. And I'm just talking about the deltoid. Okay, perfect. So here we go. So we're taking the arm and I'm abducting the shoulder to approximately 90 degrees. You can see those nerves stretching out. Now, in real life, the sternoclavicular joint, which is actually incredibly strong, would have stayed together here. But you can see the length and stretch on this fixed donor again, on this fixed donor. I'm going to show it unfixed here in a second, how you get this extra stretch over top of that tissue. Well, that can be enough to cause symptoms, especially if you have sites, one site or multiple sites of compression over top of these nerves. Okay, so we'll let this play. So we'll keep the clavicle in its joint right there, put the pec minor back into place. This is an area where I see a lot of therapists, doctors, and students get this wrong, okay? Pec minor is only a player in this issue when you get above 90 degrees. If you are below 90 degrees, there's actually a big space here where pec minor would not be compressing down. So it's above 90 degrees of shoulder abduction. Then pec minor can be a player for people with the numbness and tingling they might get in their arm from the brachial plexus. All right, so that's super cool for us to see how you stretch. I'll just play the whole thing here. How you stretch the arm up and you start to see that lengthening. Like even here, because we've taken apart all the neurovascular bundles, you can see the ulnar, median, radial nerves running down, musculocutaneous right there. They're all running down, but they would have all been wrapped together until they separate out in their own neurovascular bundles, okay? All right. So that's cool for us to see. So we'll pause that one right there, just showing you how you have to be above 90 before you would actually get tension over pec minor. Now we'll go ahead. Oh, I put it in the shoulder. Yeah, so I won't show it to you unfixed on this one as far as the shoulder ones, because I want to keep this into the cervical. So we're talking about the scalenes and everything. Now I'm going to fade into an anterior neck. Sorry, jump on that really quick for you guys, where the brachial plexus has been cut away so we can see the longus cervicis. So just so we're clear on this, I'll go back to our booklet here for our screen share. Got to get this right. Screen share to there. So longus coli, longus cervicis, we all see a lot of patients with whiplash. That is going to be muscles right on, and they're going to be deep, right on the anterior side of the intervertebral bodies, okay? And I'm going to talk about cervical degeneration here in a second as well, show you osteophytes and how they're not what you think they are, and all of that good stuff as well. Okay, so we've got that. Oops, got to go forward here. So we know where this muscle is that we're talking about. So our orientation for our donor. This is a close-up view of the anterior neck. The head is in the upper portion right here. The shoulders are down below. This is deltoid and everything right there. And we're going to let this play. Again, unfixed tissue. Look at how fluid it is. Look at the fascial membranes, how clear they are and how different it looks. And here we are flexing the person's jaw up and extending their neck back. So lateral flexion right there. As the person is moving around, these muscles, zero friction interface, are sliding back and forth. Okay. So that'll get us to that point right there. Now, I feel like I need to stop for a second and see if there are any questions. If we're palpating in, of course, we know that we would move the trachea out of the way and slowly bring ourselves all the way up right there. Do I have any questions?
I don't see anything up here right now, but we'll give people a second or two to let their fingers quickly work that keyboard.
All right. Yeah, I'll fade into one of the key things that we see: cervical degeneration, not as common as lumbar degeneration, but still relatively common. So cervical osteoarthritis, or DJD, is not a big deal. Okay, so I'm going to play another video here, and Shelly, you can interrupt me if we have any questions. I'll play another video here that's going to show us the anterior side of the neck. So here we are again, palpating through this tissue. And this is a different donor this time. But what we can see is the fluidity of, and how it doesn't look like the textbook, even though we try and do a good job of it, the fluidity of the tissue itself. And these right here, these bumps, are osteophytes. The muscles, your body adapts and everything slides over top of it. Unless you have the biggest osteophytes ever, which I'm going to show you here in a second as a variation from this. This is normal tissue. Your body is totally fine for range of motion, everything here. Look at that fascial membrane just slide back and forth, right? That's actually
Nick,
yep.
You're not screen sharing.
Oh my gosh. Freaking out here. Whoa. I'm going to go back. Okay. Freaking out. Got to go back to a screen share. Back to Zoom, back to Zoom. All you guys are hearing me talking. I'm so excited about it. And then you're not screen sharing. Okay. Keeping me honest on that. Yeah. Okay. Can you hear me now?
We are all good now.
Yeah, you can hear me now. Okay, let me go back here then. So, all right. So again, unfixed tissue, you can tell right away as soon as you look at it. You see the redness of the tissue, see how fluid it is. There is interstitial fluid and lymphatics and everything that we need everywhere right there to begin with. It literally looks like you're in a supermarket. You can see the muscle fibers right here of longus coli coming up, or longus cervicis. This will be scalenes coming up around the side right here, and especially back here a little bit further. But what I want you to visualize are these little bumps at the tip of the probe. Those are all osteophytes. They are not sharp, jagged edges like people seem to think they are. And they get covered with fascial membranes and ligaments that still exist in that space. They just get pushed out a little bit. And so in mild cases, or more moderate cases like this, in fact, it looks really bad on an X-ray, but you can't correlate what the person has on an X-ray and their actual symptoms. Look at how smooth and fluid that is right there. That's the esophagus actually that we're taking and sliding back and forth. This is, I'll even pause it right here. This is the thyroid cartilage right here. Excuse me. And this is the trachea coming down. You can see the tracheal rings coming down right there a little bit higher up. Everything is designed to slide. Your body is way more fluid than it is. A lot of people see, well, osteoarthritis, I can't joint mobilize this person. I can't move their neck around as much or anything. Yes, you can. 110%. You absolutely can. Okay. It all just winds up sliding around back and forth. Again, pretty messy as we fade out there a little bit, but yeah, super cool for us to see that. All right. So we can reach into these tissues. You have to slide the other ones out of the way, but absolutely, definitely accessible for you to get at. And it doesn't stop there, boys and girls. Do we know what DISH is? Diffuse idiopathic skeletal hyperexostosis. It is massive, massive. And here we are again on the front of a neck. Okay. Obviously a fixed donor this time. Try and pause it where we don't actually have a blur in the screen. So this is the person's upper portion of their lungs right here. We can see the rib cage coming down. This is the brachial plexus coming off to the side. This is the front of the neck. And can everybody see how large these, and I'll put it in quotation marks, osteophytes are here in front of this neck? If you look it up online, you can see x-rays of what DISH actually looks like. And it's this, what they call a candle wax deformity. It looks like somebody poured candle wax down the front of the cervical spine, or more commonly in the lumbar spine, and you get these huge osteophyte formations. Now, at this stage, because they're so large, the person might notice a change in swallowing, or they might notice that their trachea is shifted off to one side or something like that. But the body still adapts. The body still finds a way to function through that. So just wanted to show that to you really quick. Bring that condition to your awareness. It is actually quite a common condition that many people haven't heard of. Diffuse idiopathic skeletal hyperexostosis, otherwise known as DISH. Okay. All right. But it doesn't stop there on this voyage of discovery. I have so many other things to show you. I want to show you suboccipitals here really quick. So I'm going to go back to my screen share first thing, get that set up, and show you some suboccipitals.
And I'm going to ask you about when you're treating longus coli, what kind of pressure would you typically use given proximity to nerves, arteries, etc.?
Yes, exactly. So the whole thing is this. It's 5.2 newtons per square centimeter. Obviously is what you're going to use. I don't even know why you would ask that question. That's a joke, just so we know, because you can't say what the pressure is. The pressure is always going to be to the tolerance level of the patient based on the skill set and comfort level of the practitioner. Okay. So the first thing is this. Number one, if you have giant meat hook hands, it's going to be more tissue that's actually, you're going to have to push out of the way to get in there, and that'll often be more uncomfortable. If you have a patient who just doesn't like their neck being touched, or has a phobia around it, or maybe has had some domestic violence or something like that that's taken place, then they're not going to be able to handle as much pressure, and you're going to be working through more of a trust issue on that person to gradually get yourself in there. The key thing is, as long as you're not, like if I push out here and I go lateral, I'm over top of a pulsing mass of my internal or common carotid artery down here. You can actually push on it. As long as I go a little bit medial, I can feel it on my fingertip on one side. My voice is going to change here in a second as I get right in there. But the force is whatever it takes to sink into the tissue there and then gradually working through. But Shelley, you've been out to the seminars as well. You know that this is a more advanced technique. So I would never give this right at the very start. But for some of my whiplash patients, this is the edge that we use right here. It allows me to be way more specific, even my pinky finger, substantially smaller, and sink in and start to strip through the muscle and work my way through with the palpation, right? So as far as specific force, I can't give you a number of specific force, what it's going to be. There's so many factors that are into it, but you are safe to try it with the patient's consent and your comfort level as you have more experience, which is why what the MTAM does is so great, putting on all of these CE seminars for everybody and all that good content that helps you get that experience and gain confidence, right? All right. Any other questions, Shelley?
I was gonna say, yeah, thanks for the MTAM plug there.
Well, yeah, man. But that's the thing. People, like, you don't even understand how crazy it is. Different jurisdictions, like where I live, has gotten rid of CE requirements for in-person approved stuff. Like, they just will let you take anything. It's crazy. Like, it doesn't even make sense. There needs to be mandatory. You should take some, I don't even want to get started on that. I got to get back to
all right. Yeah, that's a whole different thing.
Yeah.
So Darla has asked, she says, I have a client that got kicked in the throat as a kid and is now dealing with esophagus and osteophytes. Do you have any suggestions on what we could do to help them?
Yeah, so you're not going to be able, so with osteophytes, and this is true for all osteoarthritis anywhere in the body, you cannot change the shape of the bones. That is a given for everybody, but what you can do is change the person's soft tissue flexibility and neural perception of that area. Because what happens for people, boy, I can already tell I'm going to run out of time. I can't believe the time is, how much time do I have?
You have till 3:30 my time.
Yeah, so like 50 minutes, because I have like a ton of videos to show you guys, and there's so many good cases here and stuff like that. Okay, the key thing is just working with the person to improve range of motion and to give the stimulation in the area gradually to their tolerance. But the biggest thing I would say is challenging them more than they believe they can do, with their permission, with breathing. All these basic principles that we still use can have huge effects if you apply them and time them in the right way. It's still going to be minimal effective dose. What is the least that I have to do to give you there? But it would be a good case, especially if you sent me some x-rays for us to talk about and work through. I'll play some x-rays, some dynamic x-rays here in a little bit for everybody, where we'll talk a little bit about that stuff. But that long-term trauma, it often does take a long time for you to break down the walls that the person has with that, whether it's physically the tissue changes or neurologically the tissue changes that they have in perception of pain in that area. All right.
Perfect. Thanks. We'll let you keep going.
Okay. Yeah. All right. Okay. So next thing I'm going to do is play the suboccipital video for everybody so we can see this. Again, good review for everyone. So you should be looking at a screen right now where you see the back of someone's head. You can also see their skin right here as well. So this is one of the things I try and do. In a lot of dissections, like most medical schools, skin's off, fat's off, and then they just kind of get into the tissues. And they forget the interconnections. I'm always trying to show people the connections that exist superficial to deep. So there's the skin. This would be trapezius coming up right into here. There'd be superficial adipose there as well. Nuchal ligament right down the center. And then here on this side, we'll come back. I don't want to go right. Oh my gosh, I don't want to go right in just yet. Right there. All right, so this right here is the upper fibers of trapezius that we have cut away. This right here is the posterior fibers of SCM. And yes, that is SCM. Most people don't realize how big SCM is and how far around the back of the head it goes. And you can tell that quite easily because you can see the fibers running down, and now it's going to the front of the neck, okay? So I will let this play. We'll peel back the trapezius. All right, I'll peel back the SCM here in a second. Okay, so peel back the SCM. The biggest muscle on the back of your neck for almost every single patient that most people don't pay attention to is splenius cervicis and splenius capitis. Say it with me with a smile. Splenius, okay? So when you are working on the back of the neck, you are mostly working through splenius. Trapezius is a relatively thin muscle. SCM, by the time you get up there, it's so lateral, you're only catching the outer fibers of it, okay? Here we can see levator scap coming up as well, but you see how lateral it is. If you are midline over top of the vertebral bodies, you are on splenius. It is big, it is thick, it is strong, and it needs to be that way to hold up this 10-pound-ish head with these little thin necks. I've got one patient right now who's been coming in. She plays badminton. She is of Filipino descent, and she has got a head bigger than mine and a neck like, I'll say 30% thinner. So she's always got neck tightness and stiffness and headaches all the time. So we're always working on loosening up those muscles for her. So just as an anatomical point of variation. I do have a cadaver dissection where I'll show you the opposite, where somebody with a really thick neck, what that looks like as well. But if we peel this back, that's me outlining splenius right there. So you can see the physical size of it. It is big, it is thick. Okay, and then if we come into here, we can see splenius cervicis coming down. This is levator scap running up to where it would go. Or actually, no, just wait a minute. Sorry, that's longissimus capitis running up right there, pardon me. Then this is going to be splenius cervicis right here. And that's the size of my finger as a 6-foot-tall adult man who weighs 175 pounds. And it is almost the size of this muscle right here, which is it's a little bit bigger, pardon me, of this muscle right here, which is the obliquus capitis inferior and rectus capitis posterior major. These muscles are quite a bit larger than people realize. So that's the spinous process of C2, how it runs up, how it spreads out. Okay. And what you're going to see is that it goes out to the transverse process of C1, and then they're going to run up for rectus capitis posterior minor and obliquus capitis posterior and rectus capitis posterior major, and then deep to that would be rectus capitis posterior minor. Sorry, I'm jabbering on here with a bunch of different stuff. Not a big deal. I just want you to realize the size of these muscles and how deep they actually are. So I don't think in this video I actually show the depth. I'm just showing some palpation structures of what you have to go through to get there. What I want you to see now is on our next video, the physical size on somebody with, this guy was 195 pounds and 5'9". We know this body type. When I see this body type on the mats for jiu-jitsu or judo or anything like that, it's like, and I'm going to walk the other way right now. Because these guys are basically bricks, super thick, super strong people. And they're hard for us to work on as therapists as well, therapists and doctors as well, because there's so much more muscle mass to work through there. So you can already see, here's the back of his neck. You can see coming down. His neck is as wide as his head, right? Like most of us have these more slender necks that come down, and his neck is as wide as his head. So that's already a thick neck right there. If we progress down, here we can go ahead and see where the nuchal ligament would have been. You can see me peeling back his trapezius, which is a big, thick muscle. You can see the outline of SCM right there again. You can see us peeling back. Again, I can't stress this enough. The size of splenius, that's really what you're working on for most people. You're picking up and giving your massage over the back of the neck. So we'll peel back that splenius. You can see other fibers of splenius and longus capitis as well coming up right there. Peeling back. And that's going to be the semispinalis as we peel back right there. So for this guy who is 5'9", His suboccipitals are over twice as thick as my fingers right here. Okay. Absolute 5'9" and 195 pounds. Like, and this guy wasn't overweight, it was muscle weight. They are absolutely huge muscles. And this is on the other end of anatomical variation right here. So whenever you're looking at a patient, you have to keep in mind anatomical variation, like I said at the start, is as different as we all look in a general patient population. So some people will have these absolutely huge suboccipital muscles, and you will wear your fingers and hands out trying to work on these if you just use your hands, okay? Exercise is going to be a great way to help this person. Stretching that you do as part of the therapy or that they do on their own. And then, of course, instrument-assisted techniques. You guys know I'm big on those. So that's, of course, going to be a big fit right here as well. Okay. Just wanted everybody to see that. Like, those are huge. That is my thumb. And that's like, these are the biggest ones that I've seen. And like, look at how much space that thing fans out, that rectus capitis posterior major and obliquus capitis inferior. They are absolutely huge on this guy. But every muscle on this guy was huge. And if you get somebody in your office who's a bodybuilder or a steroid user on a regular basis, the muscles just even get bigger than this. Like, this guy is still in the realm of natural body size right here. So super hard to dig in, but it would be a huge muscle that you would hit relatively superficially on this patient. Okay. I do want to show one thing here really quick. It's just going to be a super fast video. Different donor again, of course. This dissection takes a long time to do. This is really more of a discussion around the vertebral artery, which we don't have to get into right here. But I just want you to see how deep the tissue actually is. You can see this is the posterior arch of C1. This is the spinous process of C2. You can see a little bit of hair. You can see the back of the neck. You can see, in fact, the nuchal ligament beautifully dissected out right here. So we can see all of that and how deep that tissue actually is. I think I go through and measure this with my probe. Yeah. So basically, for point of orientation on my fingers, that would be about 2 knuckles of depth right there. So that's going to be about an inch, inch and a half deep right there before you reach the spinous process of C2 on somebody of normal size. And then the suboccipitals would be deep to that. Anybody who's interested, this little thing right here is actually the vertebral artery. Okay. Is the vertebral artery. Now, what I like to show people here is some dynamic movement of the neck that we can see. We'll show it on I always debate the best way to do this. I think what I'll do is I will show it for you first on a X-ray, basically. So we'll just do an X-ray first, a moving X-ray, and then I'll go ahead and show it to you on a cadaver. Okay. So you should be looking at a screen right here. This is fantastic. You can see how the person is moving in the lower left, and you can see an outline of their spine and beautiful disc shape, height, curvature right here, and where all these muscles would be and how everything moves. So you can see how the joints will be sliding back and forth as they go into flexion and extension. I wish you would have went down a little bit further, chin to chest, but that's going to be extension back. So kind of cool for us to see. Again, thinking back to those unfixed donors and how slippery all the fluid is. Oh, beautiful. Look at that flexion. You can see all the facet joints sliding and all the muscles that would be contracting and have to slide over top of each other through their fascial membranes to actually show you this movement. Okay, absolutely beautiful. Flexion and extension, relatively easy to see. And you can see how the suboccipitals, oh, we're going to watch that again. This is so good. When she goes into flexion, and I'm going to pause it. So look at the space right here. That's where the suboccipitals would be. And then look what happens when she flexes her neck all the way forward. So we're coming back into extension. So you can see how tight and jammed up they get. That's what happens when you sit in a prolonged position with poor posture. And it's actually okay to sit with poor posture as long as you move out of that position on a regular basis. It doesn't matter that much. But you can see how this prolonged posture here could lead to contracture of tissue. And that's neutral. And then coming forward into flexion here in just a second. Oops, I'm going the wrong way here. Let me get back to my video. One more. There it is. Boom. So that's full flexion right there. And you can see how much those muscles would have to stretch. How many of our clients and patients that we're seeing are doing regular stretching to lengthen out these muscles? If you do a yoga practice, if you do any kind of flexibility training on a regular basis, you're using your body the way it should be used. If you do Brazilian Jiu-Jitsu, you'll have a partner that'll stretch your neck out for you. And I do honestly believe it is a good thing for you to do at almost any stage in your life. But we'll come back to that in a little bit, okay? Super cool to see that. It's just so amazing. Once you get into the oblique views, it's a little bit harder for people to understand what's going on. I know that this is an oblique view because I can see the intervertebral foramen where all the spinal nerves would actually come out. Okay, but you can still see how the muscles have to move. Even you can see the skin folds and the muscle folds on the back of the neck as the person goes into flexion extension. Super cool for us to see that. This is just the opposite way. And then we can see lateral flexion movements here. If I was to go back on this just a little bit, this is the same stuff that we talk about when we get into our book content. Like we're trying to show this same thing right here. That's what this is showing you, is the cervical kinematics of what happens at each spinal level and how you have coupled motions when you're setting up and working on somebody as far as their own active range of motion, what you do passively. And I would again encourage passive with overpressure for the ligament stretches, and we'll see that here in neural stimulation. And the same thing with your joint mobilizations. So back to this, showing you how those movements take place. Well, that is exactly what we see when we look at it in dynamic real time on our videos here. As you laterally flex, there is rotation the opposite direction that takes place right there. Okay. So yeah, you can see the joints are gapping, the muscles that have to control that. I mean, even as something, let's even look at this. She's doing lateral flexion right here. Even something as simple as this. You have a patient come in, you assess what their range of motion is. You need to know from your basic anatomy and kinesiology understanding what tissue is being stretched, how is it being activated, and what tissue is being compressed, and what are my pain generators. And then this can directly influence, it can make you way more efficient and faster at your assessments and interactions with patients because you're thinking from this anatomical level. The problem is I see a lot of therapists, they just kind of forget the anatomy and go more hands-on, which is great because you got good hands. But at the end of the day, we need to also apply this key clinical information in a critical thinking manner that's going to result in better outcomes. Even the rotations are pretty neat here. Okay, so you can see how the whole neck has to twist to the side and twist to the side. Oh, that is beautiful. Tell me that's not beautiful. Look at that. And she actually has really great motion. Most of the rotation, as we know from our basic anatomy, C1, C2, so atlanto-occipital joint, and then you see it spread out through all of the other joints as we progress down. Okay. Man, that is neat to watch. And again, we're visualizing and thinking of all the muscles coordinating that and the things that can go wrong that can influence. Here, we're just looking at the upper portion of the dent. So this is actually pretty neat. This is called an APOM, so AP open mouth. This is the odontoid process or the dens, and these are the lateral masses of C1. And you can see how when you laterally flex, these things have to slide back and forth from side to side as she moves. Okay. Excellent to see that. Yeah, that is normal function right there. And what happens and what we deal with a lot of in our practices is when people have a decrease in overall function. All right, so that'll show you what it looks like. Living person, moving x-ray. You can't see the muscles move, but you can still infer what the muscles are doing. Now we're going to go ahead and look at that on a cadaver dissection. Okay, and if you've noticed what I'm actually doing here as part of this process, I'm taking you through the layers. We're actually peeling back the muscles, going into the ligaments, and eventually I'm going to show you even how your meninges change when you go through here too, and how they're influenced by your range of motion of the cervical spine. So if we're looking at this, try and get that down out of the way. It just pops up automatically. You can see with the tip of the probe, I'm trying to show you with most of the ligaments intact, a posterior view of the cervical spine. All of the muscles have been taken away now in order for us to be able to see this. The skull and everything is still intact. Obviously, you know this is a fixed donor, so you're not going to see as much movement with it as you would typically, but watch closely and you can see those are the lateral flexion movements. Now, because it's fixed, the ligaments don't flex as much as they should, but you can still see the lateral flexion taking place in the upper portion right here. Okay, and you can see the ligaments stretching out in the lower portions down there as well. Absolutely nice to see that. This dissection takes forever to get down here, actually, but you can see me, I'm just outlining the joint gapping right here that takes place, stretching the ligaments that would also stretch the muscles. Now, I'm going to stop this for 1 second because the question always gets asked, what limits range of motion? What is the most common end feel in your body? What really limits range of motion? Give you a second to think about it. A lot of people will say muscles, a lot of people will say ligaments, a lot of people say even bony shape, and all of those things do have influence. But the limiting factor for range of motion is whatever tissue gets tightest the first. So that example that was given of somebody who was kicked in the neck by a horse, if they have scar tissue in that area, well, we know what scar tissue looks like. It basically comes in and grabs everywhere. That's probably going to be the tightest thing. And wherever that scar tissue is, that's going to limit them right there. But if I had good malleability, good flexibility of my tissue, and you went to push into it, and then I would be limited more by the ligaments or deeper structures, right? So it varies from person to person, what they've done in their life, even what kind of flexibility training they've actually been through in their life as well. So I'll go back to the dissection here. Excuse me. All right. So we can go ahead and see these movements. So that's the lateral flexion, but you can also see how they are still coupled movements. When you do lateral flexion movements, the spinous process is still spin to the side. That is normal biomechanical function for every single neck. Okay. When you start losing those motions, that's when our smaller treatments, our more micro treatments for joint mobs. Oh, I'll pause this right here for a sec. Micro treatments for joint mobs can also have influence on these deeper structures. Most of us are experts at working on muscles, manual therapies, exercise therapies. We have a bunch of go-tos that we like to use. We need to also start looking deeper into that tissue and see how it can affect these micro movements as well, and overall neurologic function for a patient as well. So if we let this play, now I'm going to do rotation, and you're going to see most of the rotation right up here at the very top. Okay, so you can see the very top, that's C1, C2 moving back and forth right there. That makes sense because that's where our dens is, the atlanto-occipital membranes and all that good stuff. But as we twist further, then we can see the lower parts of the neck also start to twist around as well. And again, unfixed tissue, this would look a lot better because it would show you more range of motion, just like we saw previously. That's me showing just setups for some mobs. Again, kind of an awkward setup because we're posterior, but not a big deal. Okay.
So quick question from the group here. So somebody obviously uses some tools, and we're going back to actually suboccipitals.
Yep.
So given how big they are, how deep they are, what do you recommend as far as tools in treating those muscles?
Yep. So there's two things that I would recommend. Number one, you always want to take the pressure off of the small joints of your body whenever you can. So those of you who know it. So number one, I can't do pin and stretch. We're actually writing a new book right now. We're going to start filming next week actually on it. We've actually got the book written. We're doing all the video and picture on pin and stretch. For those of you who are big on rapid or active release or whatever else it is that's out there, those techniques all involve loading through your thumb for the vast majority of them, pinning and moving the person around. I can't do that on more than one person. Learn from me for the future without getting aching in my interphalangeal joints. I think the last stat, and I quote this in one of the seminars that we do on the instrument stuff, is 91% of physios have missed work because of thumb pain at some time. So what I do is I'm using instruments to start to just gradually work my way up and in, and then work this way to get back into those suboccipitals. And again, being more specific. And if you look at the shape, you've seen me do this before, Shelly, but this is literally the shape of my thumb to dig up into that space. This is literally the shape of my knuckles. Even right here, the whole design for this came from an Egyptian headrest right there. These things fit perfectly in the back of your suboccipitals. So it's a way for you to get that extra load and pressure in there where you don't have to put the pressure through the small joints of your hand. And then if you are more advanced, and you again have to do this with patient tolerance, the way that I'm getting into suboccipitals for the vast majority of people is actually this edge right here. I might do a full just traction through to begin with, but if I want my best bet for manual therapy, I'm going to use that edge right there. And then of course, that's also going to be facilitated with the exercises, chin tucks for stretching, all of that good stuff that you would do as well. I don't know if that fully answers the question, but that's my kind of quick go-tos right there.
Awesome. Thank you.
Okay. All right. So the next thing that I want to show is this in a further dissection. So just so you're not alarmed, you are going to see this person's the back of their brain, their cerebellum, and all of that good stuff. And then I'll show it with the back of the spine fully open. So here we are again, different donor this time, but you can see the back of the skull has been removed. These dissections take forever to do, but we're mainly here to show the motion. So now you can see better movement with that lateral flexion taking place, right? Twisting from side to side, just for lateral flexion. You can see each of the segments sliding back and forth. You can see us up at the very base of the skull, coming down, gapping of the joints, all of that good stuff. And then you can see me trying to, again, demo a joint mobilization that we would do right here. But we can also see the same thing with flexion and extension. Let me go back to flexion extension. Okay, rotation taking place. And yeah, lifting up into extension, bringing you back into flexion. Again, all the muscles would have had to have been on top of this and initiating and controlling these movements, but they would slip and slide nice and easily unless you've got specific scar tissue and damage inside of them, or hypertonicity because of, well, dehydration, or you name the cause potentially. Okay, so I just wanted us to see that. And then I'm going to take us one level further, because a lot of us don't realize how deep our basic therapies actually are. So this again is a different donor. Skull has been intact, but we have removed all the lamina and spinous processes off here. So you are looking at the C1 posterior arch right there at my fingertips. And then the rest of this is all the spinal cord. And yes, Upledger Institute is right, okay? In some ways, there's a lot of stuff that isn't very evidence-based, but other stuff is. You are moving somebody's spine. You are moving your own spinal cord around every time you flex and extend your neck. And I'll show another video here in a little bit where you're actually sliding it up and down your whole spinal canal by about 2 or 3 centimeters at least, even longer if you put somebody in certain positions. So here you can see the head being lifted up into neutral. And as we come back into extension, you can see all the meninges folding up. And I don't think people understand the significance of this movement right here. Now, the first thing would be if you had something like neurogenic claudication or spinal stenosis, a lot of those patients, when you put them back into extension, because this meninges accordion up and so does the ligamentum flavum, the symptoms are worse. When you put them into flexion, the symptoms get better. But our basic therapies are having effects on the spinal cord level, mechanical effects on the spinal cord level that a person may not or cannot do themselves. If they're not doing stretching and flexibility or any kind of movement outside of your clinic treatment, they're not going to be getting these kind of movements done. You are influencing cerebral spinal fluid flow by moving somebody's body around with something as simple as passive range of motion. And it doesn't get more amazing than that. You are reaching in and grabbing their central nervous system with what we're doing here. Okay. All right. So I'll let this play a little bit more just so we can see it. Yeah, I'm just talking to the class here for a second, but everybody can see the accordion up of the spinal canal, or of the meninges that you can see right there. That is actually the dura mater that you're looking at, and it would come out to the spinal nerves that would come out on each side right there. So not a big deal for that for us to see. And hopefully I show this a little bit more with flexion and extension. Yeah, here we go at the end. Yeah, I let the head drop. Flexion is a beautiful movement. And in fact, let's all stop right now. Everybody should, if you're watching this, you should take your head, grab the back of your neck, and bring yourself down into flexion. Oh, and then take a couple of breaths there. Breathing in, and then breathing out. Giving vagus nerve stimulation. Breathing in again. Breathing out. This stretch, oh, nice, is reaching all the way down to your spinal cord. And if you do it with your breathing activities, you're also giving parasympathetic stimulation that we all know and use in every practice that we give a patient. But it doesn't stop there. If we look at this even more closely, here's I'm not screen sharing. Pardon me. Good thing I caught myself that time, Shelly. Luckily, I got myself. All right. Screen share. It doesn't stop there. Now you are looking at, again, a different donor this time as well. I cannot express to you how long it takes to actually do this dissection. This is amazing work from amazing people. I just want to give thanks again to the donors and all the people that dissect with me. For us to see this is probably, I'm going to say 50 or 60 hours of work, at least, okay? But here you can see the back of the brain, the cerebellum down here, the opening up of the full spinal canal. As it runs all the way down, your spinal cord would actually end right about here at approximately L2, L3, well, L1, L2, depends on the person. And all of this is all of the spinal nerves are coming off all over the place right here. All of this is the meninges, and so it's filled with cerebral spinal fluid. And we're going to let this play, and all I'm going to do is pick up the neck and put it back down. So already this person in flexion, they're up on a few pieces of wood here to actually give a flexion of the back so we can dissect. Maybe I should show this too. Even so, we understand our layers. This is the skin up here. This is adipose layers. And yes, unless you are near starvation, that is relatively normal adipose layers that we find above the hips, okay? Love handles are a real thing, and they're actually mild ones might be a healthy thing, especially in geriatric patient population. Research is pretty clear that if you have that extra little bit of weight, you're going to probably be a little bit better off. But here I'm trying to show that this runs all the way down. And yeah, so there you can see right there. So I'm just showing us going through the ribs, and we can see those coming off. And if I lift the head off, and it's even in this fixed donor, you could see how that took tension all the way off on the spinal cord. Okay. And then if we let their head drop, we'll just move them around just a little bit here in a second. The flexion and extension movements are, yeah, you can see that that gives a pull all the way down. And I'll, like, look closely way down here where the cauda equina would be. You can see that, yeah, there's the cerebral spinal fluid. You can see that it creates tension and reduces tension. And inside of that, your spinal cord is sliding up and down, especially in living tissue, unfixed tissue, okay? And that also carries all the way down to the sciatic nerve. And this is super cool for us to see. There's the back of your brain, there's the back of your neck, all the way down, and then it would come off to the branches into the sciatic nerve that runs out here as well, deep to all of the glutes. This is amazing. I guarantee you have not seen this before, okay? Absolutely phenomenal for us to understand the interconnections on the body and how the effects of our treatments may influence these processes. You can still see the according up all the way up there as well of the back of the meninges too. Super cool. All right. Okay. So that's what I wanted to play right there. I'm going to play one more video that's going to show a pathology here super quick so we can see it. And it is going to be this video right here because we're looking at the cervical spine. So this is a moving film. I play this one as part of my advanced clinical reasoning and orthopedic assessment for people who are learning about for the upper cervical spine, basically. This person can walk into your office and they walk in with neck stiffness is why they're in. Oh, great. You've got some neck tightness. Well, I think I can go ahead and loosen up those muscles. Okay. That's going to be our typical approach for the vast majority of the population. Okay. All right. So the key thing I want you to look at is up at the very top right here. Okay. You can see the person centers up the moving X right here. This is not a good thing. So this is normal. All right. You can see as we trace up the front of the vertebral bodies, everything is fine right there. In fact, up to the dens. And I can see the alignment of the posterior SPs and the posterior arch of C1 running down here as well. If we play this, and this is what's scary, boom. Can everybody see that? Do you see how this C1 slid so far in front of C2? This could potentially be a life-ending injury right here. If this person sneezes really hard, if this person gets choked the wrong way, if this person gets into a car accident and gets some whiplash where their head rocks forward, this C1 can act like a guillotine and compress on the brain stem up here right out of your foramen magnum where, I don't know, little things that control, important processes like breathing are based. So in this case, further evaluation is required. If you keep on treating somebody and they're showing you that I keep on getting the same headaches or recurring and you're not figuring out what's going on, you have to look deeper. You have to give and offer those deeper treatments or refer to other practitioners that you trust to give these deeper looks. I'll just play the last portion again because it is pretty amazing to watch. So you can imagine, boom, that full slide forward right there, and their body is going to be working hard to try and stabilize that area. All right. I know that's kind of a scary one as an extreme example, but we'll kind of go through there. Okay. Any questions on that? That gets me through all the anatomy.
I think we're good. I think you've just scared a few people with the
oh yeah,
a lot of like, oh my goodness.
Yeah, it's not bad, but it's one of those things that, because obviously the person is stable if they can walk into your office, but it would be one of those things where if I did push you too hard, or you hear stories of like football players, like especially in kids in high school who don't know how to tackle right, tackling somebody else and their neck bends wrong and then it cuts their spinal cord. Basically it bruises and cuts their spinal cord, then it can result in more significant injuries where like high velocity mobilizations would be absolutely, because I teach a lot of chiros as well and physical therapists, would be absolutely contraindicated in that case. And even some, yeah.
Oh yeah, sorry, I didn't mean to cut you off.
No, go ahead.
So what are the cause of that, and what would be some signs and symptoms to help you identify that type of
Yeah.
issue?
So the signs and symptoms would be the person would experience, the most obvious one would be they experience bilateral numbness and tingling either into their arms or into their legs because it's compressing so high, and it's especially worse when their neck flexes. Okay. Other symptoms would be, and this is where it gets scary, if they just had neck tightness, because you have to visualize those suboccipital, splenius, all those muscles on the back there are going to be crunching down to try and stabilize that neck. Like we see it with ACL tears. I see soccer players with full ACL tears confirmed on MRI, but their quads and hamstrings will be contracting so hard when they're moving with resting tone that you can't actually move their knees. So they're physically stable as long as they have good muscle strength, and we don't loosen them up too much. So that would be an example of somebody. It's rare, first of all, that condition. So just be aware of that. Of somebody where, you know what, it's not in my best interest to actually loosen up the muscles for that person. It might actually make it worse for you.
Perfect. And what about causes? Is that injury based? Is that
so that could be
anatomical?
that could be congenital defect, that can be injury based. That injury can happen from two different things. You could have a rupture of your transverse ligament of the dens, which could have happened from a prior car accident, could happen genetically from Down syndrome, could happen from advanced, but it'd have to be really advanced, which that person didn't have, rheumatoid arthritis, or other traumas, like if they had a hard tackle. Or I've seen it from people who have hit their heads really hard. Two people, one in particular. This person was in a car accident, didn't have their seatbelt on, and their head hit the windshield, and they got jammed forward like this, and the windshield didn't break. Like it cracked, but it didn't break. So all that force went into their neck and caused that rupture, right? And usually be picked up on X-ray in an ER department, but sometimes they're missed. And especially if they just do static films and they don't pay attention to the clinical symptoms of the patient, they will be missed. And it could be somebody who walks into your office, even though it's extremely rare.
Great. Well, I think you've all made us a little more conscientious about neck treatments.
But that's it. That's the importance of all the assessments that we do, right? Like you have to do detailed assessments, which segues great into the very next thing that I'll screen share here for you guys, is going to be us looking into what we do for our assessment. So I'm just going to go through this super quick because really we talk more about it in our assessment series that we go through. All of these forms are available online. I think if you're an MTAM member, we've got them for you guys. If you guys are working on your membership platform there and stuff too. All the palpation videos, I remind you again, are online. Even this book, the way that I'm flipping through it, is available online. My assessment of range of motion, simple range of motion, does all of this good stuff I've been talking about this entire session right here. Flexion of the neck lengthens the muscles, stimulates the nerves, increases blood flow, and then stretches out the ligaments, and then takes my spinal cord and moves cerebral spinal fluid. It is just a win on every level, as long as I'm not doing it so hard that I cause further injury. And that's where we come in as the experts who can help. You can do it. We can help, because we can tell you when it's safe to move and not to move. And I'm going to talk about this as my last thing when we just finish up here. I know I'm running short on time. Passive range of motion, again, gets you into these areas and gives you that little bit of overpressure that makes your assessment therapy. I would encourage you all, with every single patient, active range of motion and passive range of motion with overpressure. Okay. And I would encourage more seated treatments as well, because that's how a lot of us spend our time. So I show passive range of motion in a seated position. I'll often put somebody into flexion and seated, and then immediately go into lengthening out those big long muscles with some nice bowing and stripping and stuff like that, and instrument assisted right from seated. I have patients who come in, they see other therapists, other massage therapists, and they come and see me after that because they need deeper or more specific work, right? All right. Your muscle testing is still a win for this person. Try and isolate what specific muscle might be damaged. That splenius muscle test is a test I would encourage you all to do a little bit more. Our basic orthopedic tests, we started off with the brachial stretch test. Make this test therapy. Oh, I get numbness and tingling. Great. Let's go ahead and move into that a little bit and then come on out and improve your tolerance with every visit, where we gradually, with baby steps, challenge you into those movements. Okay. Cervical compression and distraction. I mean, I hope everybody who's watching this is using a cervical distraction test. Right away, when you do this on somebody, you hold their head up and they're like, oh, that feels great. You know what half of your treatment is going to be for that person. It's distraction based. They need to have the pressure taken off, right? And of course, reviewing and going through this is another great one for whiplash. Joel's neck flexion endurance test. It's a rehab exercise as an exercise and treatment, but it's also an assessment. How well can you hold your head up? I can't tell you how many patients I've seen with whiplash, and just using this simple test right here has been a win for them, empowerment for them, okay? Because you can do it on your own. The imaging stuff, we've already gone through that enough, so you don't have to worry too much about that. And then, of course, I break it down condition by condition in the book, or we can do even better than that. We can go into our massage therapy book and the same thing, which is what's going to get into where we're going to get into most of our treatments right now. So this one, again, available through the MTAM. This is the second edition. We've updated now into the third edition and made the book a little bit smaller and more affordable for people. But what are we really doing with people? I hope that everybody has seen this acronym right here: peace and love. The first thing when somebody has an injury, we just have to protect the area. And that's relative protection. You don't want to injure it again, but you don't want to baby it too much. You do have to challenge these tissues early. Elevation does help. Avoiding anti-inflammatories. This is the big news for a lot of people. A lot of people think, well, I got to take my anti-inflammatories. No. Inflammation, your body has evolved over hundreds of thousands of years. Inflammation, when it's happening the right way, is a necessary and good thing. Do not knock down the inflammation. In fact, if anything, support the inflammation. All right. The next thing is going to be compression can help if there's a lot of swelling or potentially in a compartment type syndrome. That's where elevation and compression may become more into play. That's if you have excessive amounts of swelling around a tissue, which can happen anywhere in the fascial planes, as we saw with our unfixed donors. Education is key. We are, all of us, experts in our field. Express that education to your patients. Why do all of our mini books say you can do it, we can help? Patients ultimately do everything themselves. We just influence and empower in certain ways and point them in the right direction with yes or no, you can do this or you can't do that. Load is key. For those of you who have been with me before, you know one of my favorite graphs, one of the best pictures I've ever drawn. You have to load a tissue to heal a tissue, and I'll end up with that one right there. Optimism. Everybody who comes into my office, it is optimistic. I give them the sandwich where this is good. These are some things we can do better, but you've got all of this by the end of the visit, okay? The feedback sandwich is key. Vascularization. Excuse me. By moving somebody around, you are improving vascularization. Active range of motion does more for vascularization of deeper tissues than you can do with your massage therapy treatments. We have to get people moving. Superficial, that's debatable, but deeper tissues, the further down it is, the harder it is for us to get force in there. And of course, even better vascularization, because the normal physiologic response when you exercise is to increase vascularization. And we know the more blood I get to a tissue, the faster it heals. And if you look at this, I love the way it's even set up here: education and exercise at the very ends. These are the key things that we do. Okay. All right. Flipping the page here just a little bit. You've probably seen this graphic from me as well before. I'll come into it in just a little bit. I do want to make just one quick reference on this. If your people are not sleeping right, you are fighting an uphill battle. The best success I have had, and especially people with fibromyalgia, is physically just getting them to sleep a little bit better. And we can motivate people to do that. We are all cheerleaders. We all have cinnamon buns. And we'll find out what that means more in just a little bit. Yeah, this is a little bit later on. Treating, yeah. So this just back here just a little bit, working with pain. Everything you do, every time a patient comes in, you should be asking, what are your goals for today's treatment? Sometimes it's going to be relaxation massage. Sometimes it's going to be specific medical type massage. Meet the person where they're at. And I talk into that in more detail here, but not a big deal. The big graph is this graph right here. If you've got it, screenshot it. We put it on all of our posture posters and all that kind of stuff where we use this stuff. But the bottom line is I have to load a tissue. And this is a graph that I talk about again and again because it relates directly to tissue healing. So this is the tissue strength on the one side and the tissue and the time over here. And the biggest thing for you to get is this black line that runs through here. Inflammation, proliferation, and remodeling. That is how the body heals. And what happens for most people is they need to be loaded in about this 3 to 5 day range. You can give yourself a couple of days of relative rest, but the sooner you load somebody, the better the outcome is. And that means loading them from you or loading them themselves through basic, simple exercises and challenging them more sooner. Your body is far more resilient than you realize. We just need to give people the permission to get back at it sooner. So if I look at this graph right here, you can see at this 5 to 7 day mark, this is when I really start laying down more collagen. In this book, we have 10 pages with over 100 references talking about different tissues and how they heal and all of that. And it is clear that the sooner I start to load, the better the orientation of fibers, the better the neurologic innervation, the better the psychosocial understanding, the better the outcome is. And you can get people back to better than the strength they had prior to the injury if you load them right and you load them early. Okay. So again, say it with me. You have to load a tissue to heal a tissue. I'll say that one more time. You have to load a tissue to heal a tissue. So I'll exit out of this and I'm going to finish off for, oh my gosh, I'm almost out of time here. I'm going to finish off with this PowerPoint presentation right here. This is the graph right here. For those of you who don't do it, follow me on Instagram. I post this stuff up all the time. If you have other questions, I will post things for you there. It's just at Dr. Nikita Vizniak. I post this one. I try and post it once a month, just as a reminder for everybody. Our manual therapies support the entire rest of this process, and don't get overly hung up on diagnostic imaging, okay? I'll come back to it. Nutrition matters. If I had more time, it's a whole separate lecture to go on to this, but not a big deal. Assessing goals, beliefs, and biopsychosocial is going to be key. Sleep hygiene, absolutely. We do this because we have long appointments with our patients and we assess mobility, strength, and neurologic function as one of the best practices for musculoskeletal care. And just so we're clear, this is based on systematic reviews, meta-analyses. Like these are big time articles that show us what actually works right here. Okay. All right. Next slide. Not a big deal for you guys to look at, but it just shows you asymptomatic findings on X-ray. Just because you see it on an X-ray or MRI does not mean it is the cause of pathology. And you have to get this across to patients. Patients who read their reports often have worse symptoms. And this is for the low back, but it's the same for the head and neck. The imaging report makes the person feel worse. Your assessment is therapeutic. Normalize these things, have that optimism, positivity, education, and empowerment for the win for these people. Everybody should be moving. There is a normal range of activity that we should be following. If you go beyond that certain range of activity into exercise, it's great, but even too much exercise can be a bad thing. I see a number of CrossFitters. I see a number of jiu-jitsu guys as well who have been practicing and their fingers and hands are all gnarled up because of excessive loading. There's the right amount of load. And the same thing at the opposite end. We know that immobilization causes atrophy and damage to tissue as well. The last thing I'm going to finish off with is this graph right here. Most of you have seen it before. I don't know if Jeff's watching this, Jeff Dalhousie's watching this, but it's one that I give all the time. I know you guys have asked to use it at the MTAM as well. I'm big on making infographics based on all the knowledge and data that I'm looking at and trying to figure out what is the most minimal effective thing that I can do for people. This is huge. You have an injury, you have body damage, you have pain. Pain is an interpretation of threatening information. And we all do this. It is a normal response, catastrophization, which goes into fear of re-injury. I don't want to do that again. And that's good. You should have that response because you don't want to hurt yourself again. But we take it too far. We go into hypervigilance and avoidance behaviors that lead to disuse and depression. And this cycle continues. And you can hear the patients say it because they are basically stuck with, if I get better. They cannot visualize future wellness. And we've known this for more than 20 years, okay? What is our job as super therapists? We take people into low fear. We tell them, yes, you can return to activity and we're going to see better recovery. And the person will tell you this by the words they use because they can visualize future wellness when I get better. What is the biggest thing that we do for patients? Wait, right back to that first picture right there. Our manual therapies facilitate all of these other processes right here. Okay, we support people, and we're all going to stop the screen share right here. I need you guys all to do this with me. We're going to take our hands, you're going to curl them both in like this, and you're going to make these things called cinnamon buns. And I wish I was a cheerleader, but guess what? We're all cheerleaders. And what do we do for patients? We raise our hands above our heads in a power pose, and we say, step forward. Yes, you can. And I need you all to do this with me right now. What are you all going to do? You're going to take your cinnamon buns, lift them up and say, yes, you can. Okay. Say it with me. Even just putting your hands up puts a smile on your face. Get your patients to do that and they will feel better. High five, cinnamon buns. Yes, you can. All right. That was a bit of a rushed presentation. I realized I covered a lot of content there. Key things for you to get out of this. Number one, The body is not how you learn that it is in textbooks. We can do the best we can for our basic understanding, but I would encourage you all to at least do a cadaver dissection on a fixed donor and then do it on an unfixed donor and see how even your palpation might not be what you really think it is. I'm going to be doing a bunch of presentations in the US on just basic palpation with these videos to support how things are different than you think they are. The next thing is going to be that there is huge anatomical variation that you see from one person to the next, as different as all of us are. We should follow the acronym of peace and love. Something as simple as range of motion has huge value for your patients. Our hands-on therapies are what the key things that we offer that are going to also be there to facilitate all of the other healing processes that people need. And the single biggest thing I can give you is that you can do it. We can help. Cinnamon buns out. Yes, you can. Okay. Cinnamon buns. Yes, you can. All right, Miss Shelley, that's what I have for you today. Thank you very much. Let me see your cinnamon buns. Where are they?